Okay, everybody, thank you for joining. Thank you for being here with us this morning. It is right time to start, so we'll go ahead and jump in. This is Seth Sinclair here, President and CEO of Plan 4 Healthcare. Some of you guys may be familiar with us, but for those who aren't, we are a small business located in Northern Virginia, and our focus is on providing planning solutions and tools, and certainly in VA, where we're working with 20 different VA hospitals at this time. And great interest in this session so far. We're very pleased to see that. Lots of registrants from all across the country. So certainly, again, appreciate you guys being a part of this session today. This is our third webinar. We have done two previously that are posted up on our website, and we can share some details on that with you. We will be recording this, and for anybody who's registered, we'll send out a copy of that, a link to that once we're done. Our goal here is knowledge sharing. This is not intended to be any kind of a sales pitch. We're just simply hoping to share some best practices with you guys in the system from our observations and from our expert team. The format for this webinar will be mostly discussion style between myself and Dr. De Nino, who I'm going to introduce here in just a few minutes. You may ask questions using the GoToWebinar tool, and so do that. We'll try and keep an eye out for those and see if we can address them either once they're asked or perhaps toward the end of the presentation at least. And just to point out that we will do some polls. We're going to have 4 or 5 different polls as part of this, so we would love for you guys to be engaged and to get your feedback on what we're going to present today. We will stop sharply in 1 hour and wrap up and let you guys move on with your day. But for now, let's go ahead and move forward and just talk a little bit about our goals for today's webinar. We picked this topic because we observe very regularly VA. There's a lot of data out there. As a matter of fact, the scope of this healthcare system perhaps maybe has as much or more data than any other healthcare system in the world. At the same time, there's a lot of questions on how do we use it? Can this data be trusted? How do we make different databases, data sources work together in order to make good decisions? And can you really be confident when it comes to decision making? And because we see that, we'd like to see if we can speak to some of those challenges just a little bit today, and then look at 3 actual examples. They're real life examples in that they've been drawn from work we've done. Although we've made them generic, I think they are telling and things that you guys would see in the course of running your hospitals and making the types of decisions that you guys need to on a regular basis. So again, Seth Sinclair here, President and CEO of Plan 4 Healthcare. Had the privilege of working with many different VA hospitals. I'm visiting one right now as we speak across the country. And my focus is trying to make sure that we do a good job in our delivery and that we're doing a good job supporting strategic and operational planning. But what I'd really like to do is introduce our esteemed panelist here, Dr. Lou De Nino. I've had the privilege of working with Lou for several years, and I think, for me at least, he is the only PhD level healthcare economist that I've come across. So Lou, thank you for being here, and would you take a moment to introduce yourself?
Hello, good morning, good afternoon, depending on where you are right now. I'm happy to be here on this webinar, and a little bit about myself. Many of you, I think, already know me, but I've been working with Plan 4 for several years and really trying to support them with strategic analysis, mainly to inform their strategic, tactical, and financial planning that they do with many of the health systems around the country. This work, by the way, has resulted in changes to care delivery at many facilities across the country. And I think we have actual measures that show that quality, efficiency, access, and financial performance have all improved as a result of our work with them. About myself, I've had about a little over 30 years experience as a health services researcher and a strategic analyst and planner. I have over 20 years of experience working directly with VA data. My last position before I left VA, I'm a retired VA person, I was Director of Strategic Analysis in the Office of the ADIS for Policy and Planning, and my PhD, in case you're interested, is from the University of Pittsburgh.
All right, Lou, thank you so much. Again, glad to have you, and a special thanks for being willing to take a selfie so that we could feature you on this slide here. Thanks for doing that.
You're welcome.
Okay, so let's jump right in. So I alluded to this in the beginning. There's no dispute that data is there in the VA system. It is certainly collected. And again, perhaps at a level of more than any other healthcare system in the world. And yet at the same time, so many people in the system are either unclear on what's available or maybe they can't trust, they feel like they can't trust what they see. So Lou, can you talk us through this a little bit? Why do you think this is the case within VHA?
Well, for one reason is I think that people at these health systems around the country have a conception of what their workload is through the daily reports they get. And sometimes when they look at data that come from different databases, it doesn't match what they believe they've been seeing. And when you go from one database to another in VA, very often you can get different answers. Very important when you look at data that you want, particular data that come from a particular database, that you really understand what the data definitions are, how the data are derived, because different databases may be assembled to answer very specific kinds of questions, and that's why they may be assembled differently than they are somewhere else. But it's very disconcerting people to go from one database to another and it doesn't match. And it may not match their conception of what they think their data should look like because the data that are going into these databases and are flowing from the medical centers, they may have coding issues, other kinds of issues. So when you look at them in the database, they don't quite match up with what you think you're seeing at the medical center. So those are the things I think that are confusing people, causing some distrust. But what I want to emphasize about data is that what you really need to be looking at more than whether the data are precise, whether it's an exact measure, really focus on trends. That's what's really important.
All right, that's a great point, Lou. I agree. Those are the exact concerns that we do hear come up. And, I think there is even a third aspect, which is just overwhelm, just with the sheer scope of information that's out there and really not knowing where to look. And so, before we move to the next slide where we're going to talk about that a little bit, I just do want to point out, Lou, you have a nice framework here when thinking about this idea of, I've got a problem. I'm trying to figure out how to organize a plan to attack this problem from a data perspective. And this framework here of these 3 questions to ask. Can you cover those really quickly before we jump to the next slide?
I think you need to think about the problem and think about, gee, what am I going to need in order to answer this? What data would I like to have? What data might be available to help me answer that particular question? If we're talking about locating a new multi-specialty clinic, we're going to see in a few minutes what the trends are in the growth of workload in that area. What about the growth of enrollment in that area? A number of other things that we'll talk about in a minute. Next thing you need to consider is how should I analyze the data? How can I put the data together in a fashion that it's going to allow me to answer the questions that I have? And finally, how do I take the data analysis and turn it into information? So how do I take what I'm looking at, interpret it, so that I can use it to support a decision?
Okay, very good. It's kind of like a, excuse me, like common sense framework to get yourself organized so that when you jump into the problem, you're not, swimming among a sea of information with really no clear direction on how to get from where you are, ultimately to be able to come up with some kind of an outcome that's helpful. So thank you for outlining that. And, before we get into the examples, we did want to take a moment here. We're not going to read through this slide. As you guys can see, there's a lot of information on here. But just to talk about the big picture types of data that are out there and, some of the key data sources that are there. So, on one hand, this slide breaks it down, in a nice organized way. I think at the other hand, it reveals, how overwhelming it can be to look at all the different things that are out there. So Lou, would you mind maybe just a few seconds or, a few minutes on some of these key areas and some of the data sources?
Sure. First of all, there's demographic and utilization projections, and those come largely from the Rural Healthcare projection model. You can find in those data cubes both bed pop and enrollment. You can find utilization trends, both acute and non-acute. They are broken out by facility, but then you can also look at geographic patterns of utilization. So you could look at geography, you could look at markets and submarkets around the VA and look at what those trends are. Then something that we need to be really cognizant of nowadays when we talk about VA care is care in the community. And that's something that with the Mission Act is probably going to grow. And this care is both care that's purchased directly by VA facilities as well as care that might go out to, well, it was choice. I have choice out here, but now is going to be something else as a result of the Mission Act. And so it's good to look at what those trends are, what's going out to the private sector, what type of care, and what areas in terms of geography that care is flowing from. Then there's the in-house care cost. What does it cost to produce this care within the VA? And we usually try to break that out in terms of ambulatory and primary care and all the specialties. Also acute inpatient care, non-acute care. And for acute inpatient care, we usually try to break it out by DRG. Quality, and here I'm focusing mainly about UM. We look at UM trends in terms of readmission rates, lengths of stay, continued stay reviews, admission rates for ambulatory care sensitive conditions. These are all things that affect utilization. These are all things that are also associated with quality. Capacity, utilization, and efficiency. And this is where all those wonderful data cubes and all those wonderful databases that OPES produces really come into play. There's physician productivity. There's the Spark tool, which allows you to look at productivity of all the different variables that are affecting it. And so you have a particular facility, you can look at what other things, obstacles a facility may have in improving productivity in certain areas. You can also look and see what your staffing is using the MCA or DSS-ALB data cubes, etc., which really allow you to break it out by different types of personnel and how they are allocated to different services. And finally, it's also useful to do benchmarking. And when you benchmark, I know in the VA, it's very customary to simply take a facility and say, oh, you're a 1A facility, or you're a level 2 facility, or you're a level 3 facility in terms of complexity. But it's very important to look at where do you fall within that complexity level. Are you, if you're, let's say, a level 2 facility, are you at the top of the level 2 facilities in terms of your ranking, in which case you may be more similar to some facilities that are a lower end 1C? Or are you the bottom of the level 2 facilities? So there may be some facilities in level 3 that are close to you. It's important to look at the whole array of facilities and be able to pick out the ones that are really match closely in terms of the kind of work that you do, the kind of residency programs you have, and the kind of specialized programs you have.
All right, very good. Thank you for covering that, Lou. I think this is a good list here. It doesn't maybe reflect every single data source that's out there, but I know that in the analysis work that you do, this pretty much is the body of the data that you primarily focus from. And I guess the secret sauce, if you will, is the ability to look across all of these. And as you pull information out from each of these areas, to put them together and see what kind of picture is drawn from that analysis, as opposed to only, looking at one thing at a time and trying to figure out what they mean. And the only other thing I'll point out, one thing I've observed in the work that we've done is sometimes there gets to be a little bit of a confusion in the difference between projection data versus actual data. Sometimes you see people looking at them almost interchangeably, and that seems like something that's worth pointing out. And we'll talk a little bit later, once we get further into the examples, what really lies behind that projection data and can it be trusted. But thank you for covering this, and let's move forward just a little bit here, and let's do our first poll. Before we start with our very first example, we did want to ask everyone, and so here we go. I'm going to turn this poll on here, and our question for you guys is, on a scale of 1 to 10, how familiar are you with VA databases? So we're asking you guys to do a little very simple self-assessment here. You're either not familiar at all, you're assessing yourself as having a working knowledge, or if you feel like you're an expert. And don't worry, we're not tattletaling on anybody who gives themselves a not familiar at all ranking. That's quite all right. But we'll leave this open here just for a few seconds and let people self-assess. I think what we're seeing, I can kind of see the results coming in, that you've got most people saying that they've got a strong working knowledge, which is probably what you'd expect. A couple people saying they're not too familiar. And let me just let this run here for just another second or two, collecting responses still. And anybody else? Last call for votes before we close the poll. And when we do, it should give us a nice little view of what we got here. So I can see the results, and I can see that. Let's see if I can share this for you guys. So we had 81% identify themselves as having a working knowledge, and a couple folks on here who see themselves as an expert. So thank you for sharing that, and that'll set us up to now move into our first example. So here we go. So we've got three. Let me just lay these out really quickly. One is related. The first one is focused on access, and we're going to look at a question about whether or not this medical center in this scenario may want to consider an expansion into a particular area. Second example is related to some specific decisions around primary care, what might be the best way to handle some imbalances between demand and capacity. And then the last one, we're going to look at something more related to cost, specifically to inpatient cost and whether or not they seem like they're in line or out of line. So with that said, let's jump into our first example. And Lou, can you cue this one up for us? You want to give us the background, and then we'll start looking at the data.
Sure. In this case, we have a VA medical center. By the way, we're not using names of facilities, or we're hiding names in order to protect the innocent. All right. So this VAMC lacks capacity to meet current as well as growing demand. They have appointment wait times that exceed the benchmarks. The new drive time, wait time and drive time standards that are going to be produced as a result of the Mission Act may push a substantial portion of this care out to the community, potentially affecting future VERA allocations. Opportunities to outsource this care through contracting, fee care, or community care is actually limited, however. So they don't have many alternatives, or the private sector is just as jammed up in terms of waiting times as the VA is. And so the strategic decision is, should this VA healthcare system expand services and locate a multi-specialty clinic in a fast-growing market area, really a sub-market area, an urban area, that's about 100 miles away from the existing medical center. So you have a secondary urban area, 100 miles away from the medical center. It's growing, and the question is, in order to alleviate some of these issues in terms of wait times and growing demand, might this be a place where you should expand and locate a multi-specialty clinic?
All right, perfect. Okay, so we've got ourselves set up, and just like we said earlier, the framework for attacking a problem like this or an opportunity like this, the first thing you got to ask yourself is, what data, what do I need in order to make an analysis? So what are the types of things we'd like to look at here in this example?
Well, you want to know what's expected, what is and what's expected to happen with regard to growth in veteran population and enrollment. You want to know what the projected future demand is for ambulatory services. You want to have some assessment of what the current capacity is in your health system, wait time and access performance. So in other words, right now, a lot of this workload is flowing to the mother facility, so to speak. And is there more capacity to absorb this, or are they pretty much maxed out, or going to be soon maxed out? And then finally, you do want some sense of, I know we said before that there wasn't much opportunity to purchase care in the community, but you probably do want some sense for some of the services and making a decision as to which ones you might include in a multi-specialty clinic, or what your in-house costs versus what community care costs might be if you were able to purchase it.
All right, very good. Well, let's get into the data then and take a look at an example. We're going to start here with our first slide. And now, Lou, this is projection data. So what are we looking at here?
We're looking at veteran population, and this is for this secondary urban area submarket. And we're looking at the veteran population and how it's expected to grow over the period of time from I started here in 2016 and going out to 2027. And you see we're starting from about 660,000. It's going to exceed, excuse me, 65,000. It's going to exceed 70,000 by 2027. That's what's expected. And look at what's happening, with enrollment. You're starting with about close to 44,000, and you're expected to exceed 50,000 by 2027 in terms of enrollment. So this is an area, this submarket that is in a growth mode right now.
And that's notable because, having looked at quite a few of these projections over time, that's not the case in many markets. The fact that you actually have projected growth here, we know that veteran population overall is declining, and so in many markets you're seeing that flat or declining. So this is significant. And let me just ask you, since we're on this slide, Lou, I have to ask because it's going to come up, and it always does come up. Can you really trust this type of projection data? A lot of people really, kind of write this off. They don't believe it, and yet at the same time, I think you can make an argument that it is quite credible. What's your sales pitch on using this type of projection data?
Well, I think on the demographics, I don't really hear a lot of questions about whether or not people believe the demographic projections. I think it's more on the utilization projections. And one of the reasons why people have a hard time buying into it is when they look at the baseline of the utilization projections, it may not match the baseline that they see in other places. And I don't want to get into all the reasons why it might not, but that right away kind of causes them to have a lot of questions. But remember, that what you're really looking at when you look at the projections is the trend. So the baseline may not match because you may be looking at baseline in terms of MCA data or other workload data that you can pull up from the corporate data warehouse or from one of the VSSE workload cubes, and you don't see the match with that baseline. And there are many reasons why that might be the case. But it's the overall trend. Also, you may be looking at the trend in your workload year by year, and maybe you're seeing, workload growing by 1 or 2% per year, and now you're looking at some of the ambulatory projections that show it's going to grow a lot faster than that. And that's very important in that when you look at your workload, and you're just looking at those workload databases that I just mentioned, and just trying to project off of that on your own, you are not making the kinds of demographic and utilization adjustments that the model makes. The model considers the changing, the aging population and the effective age. The model considers how diagnoses are also affecting utilization. There are so many different factors that are considered. The biggest one I think that's propelling ambulatory projections is of course aging. The veteran enrollees are becoming older as we go out in time, and we know, for example, just looking at the Medicare population, that as people in general become older, they have more visits. They have more primary care visits. They have more specialty care visits. They have more ambulatory surgeries. This often results in even more acute care in terms of hip replacements, other joint replacements, etc. And that's the thing you miss if you just take a straight line projection off of your workload data.
Good stuff, Lou. Thank you. And I think I've heard you also say before that, when you go back and some of this data is revisited, I'm going to go ahead and move. You're right. I probably asked the question a couple slides too early in terms of what types of projection data is out there. But I've heard you say before that if you go back and look, did the projections in fact come true? That when you're looking a couple year, at least in that shorter time horizon, maybe 5 years, that in fact a lot of the projection data does hold to be true within a very small margin of error, which is remarkable considering all the variables that go into it.
That's true. That's true. Now, we have heard from a couple of places when we go out around the country They might take a particular projection and they might say, gee, you're not showing any workload for this particular type of mental health program. And when we look into that, we find out that that is care that they are purchasing. And when they pay for it, they have a special way of paying for it that is outside of the fee cube. It's not even getting into choice, some sort of special arrangement they have. And as a result, the model isn't picking it up because it doesn't have any data to pick up on. And that's why it's missing. So it's very important to if you see that kind of a problem where you know that there's workload in a particular area that's being mixed, you really need to work with the Office of Enrollment and Forecasting to see what you need to do to kind of remedy that.
So that's another great point. So if you see this data and you're questioning some of those assumptions, that you can in fact go ask for help and potentially have some of this remodeled to account for some of those variables that otherwise they may not have known. And so it's not like you can't go back and see if these can be refined based on your particular needs. Great, that's a great point. Well, now moving forward with the example, Lou, so now we're looking at projected enrollment. So what are we seeing here?
So we have veteran population, and of course, as you know, not everybody who's a veteran necessarily enrolls. So here's projected enrollment. And on the green line, what you're seeing is this is the projected enrollment around the VAMC, the medical center submarket area. So the area around that submarket. And this is a projected enrollment around the secondary urban area submarket that we're looking at. And we notice that going out to 2022, the area around the medical center is actually growing a little faster than is the case in this secondary urban area, although it is growing considerably at 8%. But going out to 2027, look what happens. You see here that the enrollment growth tends to flatten out for around the medical center, and in the secondary submarket, it just keeps growing almost like a straight line. So they're going to experience 12.2% growth in the future versus 8.5% growth in enrollment in the medical center submarket.
Okay.
So
certainly some potential in this market. It's from what we're seeing so far.
Absolutely.
All right. So here we go. So now we're looking at demand specific to this secondary area. And so Lou, I'm not a PhD, but I'm seeing upward trends here. It looks like some growth is expected. So what are we looking at here?
Well, what we're looking at here is, first of all, is ambulatory care, and this is what you're going to see almost everywhere around the country. Ambulatory care is a growth business, so to speak, for VA. Lots of increased demand. Look at primary care. Primary care is growing. It's expected to grow very rapidly. Ambulatory mental health is also expected to grow very steadily over the next decade. And ambulatory medical specialty care has a very rapid growth, particularly over the next 5 years or so, before the rate of growth begins to slow down. And this is for that urban area submarket that we're looking at. And we see that all of these forms of ambulatory care are expected to grow very significantly.
And Lou, just to clarify, what are those units? What are we measuring here when we look at this projection?
In this particular case, we are looking at relative value units. So
Okay.
We're looking at projected RVUs. And relative value units is a measure of provider work. They're the same measures that are used in Medicare and the VA is using. And last year, for the first time, VA projected RVUs. They did withdraw those projections because there were some problems. But when the new projections come out, they will be in terms of RVUs. And so for the purpose of illustration here, I decided to keep them.
All right, very good. Okay, so just a little bit more demand data here. This is even more discrete down to ambulatory, surgical, and dental. Similar trends?
Correct. Very similar trends, not quite as fast as in the previous slide for the other ambulatory specialties. I want to point out dental. Dental is not RVUs. Dental is the number of dental procedures.
Okay. All right. Very good. So that's sort of, we've gotten a good picture of what the future may look like for this market. And so the next area that I know you wanted to address was, okay, well, how are we doing in terms of, current capacity and efficiency regarding serving certain patients? And so I think most folks may be familiar with this report here. Why don't you walk us through this and help us understand what we're looking at?
Okay, OPIS, as Office of Productivity, Efficiency, and Staffing, has been putting out lots of different types of reports and data regarding physician productivity. And then they have a Spark tool which characterizes different specialties in terms of being efficient or over-resourced, under-resourced, or optimized. And then looking at capacity. And when looking at capacity, all they're really doing here, and that's here potential capacity. All they're really doing is looking at how many providers are in each of these specialties, and if they were all meeting the productivity standard, does this specialty have any additional RVU capacity? That's what they're really measuring. So this is kind of a tool that kind of brings the productivity data together from a number of different reports that OPIS produces, so that you can see where you have where you're inefficient or over-resourced. You can also see specialties where you have additional capacity. So, for example, in cardiology, you see that it's considered to be inefficient. That the productivity standard is above what the actual productivity is. And when you adjust that for the number of providers they have, they could actually have additional 1,000, almost 1,100 RVUs that they could produce. And so if they were to realize all that capacity, they could improve by 6%. Notice, though, when we talk about this, it's important that we get a lot of pushback when we present this data. And remember, this is VA data; we don't produce these data, and we get a lot of pushback. And I think it's because a lot of providers, especially, view this as being aimed at them like someone shaking a finger, and that's not what this is about. Providers may not be sitting around twiddling their thumbs, and the vast majority of them are not. The problem might be there may be obstacles in the way the practice is organized that doesn't allow them to really maximize their productivity. They may have inadequate support staff. They may have inadequate number of exam rooms, just a number of different issues that may be impacting their ability to be as productive as this productivity standard says that they should be. All of that has to be looked at, and if you were to look at the Spark tool, you'd be able to see that.
All right, so in this case, we're seeing a facility that has quite a few specialties that look like there may be some opportunities there. And so, but again, it begins to further paint the picture of this overall scenario where, we're trying to figure out does the current medical center structure have the capacity to see these potential patients, and does it make sense?
Right, and one thing I do want to point out before we move forward is that although there are these inefficiencies, so to speak, and there are some additional capacity, the additional capacities, for the most part, with the exception of GI in this particular case, or OB-GYN, or plastic surgery, most of these are very small. So although there are some opportunities here, for the most part, they're fairly close to being maxed out.
Gotcha. And that is important to this scenario, absolutely. And so, moving forward one more slide here, similarly, you're looking now at wait time, which is a crucial variable. I can only imagine everybody is familiar with the SAIL reports and certainly the access and waiting time metrics. So this is another very important data point for this sample medical center that we're looking at here.
Yeah, and just very quickly, if we just, I'm just going to talk about specialty care access questions, primary care, mental health, specialty care, and wait times across the same three. For this particular facility, we see that they're performing well below the benchmarks in just about every case. They may be a little bit closer in mental health, a little bit closer in specialty care, but overall they're not performing well. And you look at the and this access questions that come from data that on customer satisfaction surveys, veteran satisfaction surveys, we see the perception is they're not really doing very well at all in terms of access.
Okay, so the picture continues to be painted. We've looked at some demand, we've looked at some current capacity, and then certainly the wait time situation in this scenario. And then we've got one more data slide here where we take a look at cost related to community care and fee. And so what are we taking away from this slide here, Lou?
Okay, this comes from I took this from the VSSE's non-VA Care Cube, which is community care and fee data that VA, this facility actually pays for. And it allows you to break out by CPT code for all outpatient services, and you can see the number of patients served. You can also see the volume so we're talking about colonoscopies, the actual volume that these patients used. You know, it's probably close to a 1-to-1 ratio in this particular case. The total amount that was dispersed, you could see the cost. You could also see the cost per unit. So this exists, and this is not, obviously, the list of CPT codes goes on and on and on. But so this is just a subsection of that report. And so if we were to focus on colonoscopies, what we see here, what we glean from this, is that if you're looking at whether or not you should perhaps buy a particular specialty versus produce more of it, or at least in terms of procedure like colonoscopies, if you were to do the math on this, what you would find is that with the most recent data available, the in-house cost was about $702 versus $644 in the community. So the community is actually a little cheaper than the VA in terms of colonoscopies. However, as I mentioned earlier in setting up this case, it's also true that it's difficult. It may be difficult to buy this in the community. So you'd really have to check to see whether the availability is there.
Okay, so that's a great example because on paper it looks like there may be an obvious outcome, but more research would need to be done on availability, and there's always non-financial considerations that are going to be part of these decisions, of course, as well. So with that said, we'd like to ask you folks who have been following along with us, you had a chance to review the scenario and see the data. And so going back to our question, which was, what should this medical center really consider based on, everything we looked at, the demand data, what you're seeing in the market, some of the efficiencies and challenges at the current medical center, and then, certainly there's some cost considerations here. So we probably queued this up to have a fairly obvious answer, but we wanted to ask you guys before Dr. De Nino runs through his conclusions, what might this medical center choose to do? Should they go ahead and expand or perhaps not? And so please, I would love to get your guys' thoughts on that. Simple yes, no answer. And I'll leave this open here for a second and give you guys a chance to catch up. And then we'll see what the group says, and then we'll let Dr. De Nino run through his view. So far, we got more yeses than nos. I'll give folks a little bit more time to vote. Still coming in. There's no election fraud here, folks. This is all handled electronically.
This is how we should do our elections, huh?
Very confident in the outcomes of what we're capturing here. All right. And so let me reveal the results here and share them. And we're going to see that, obviously most folks here are, leaning toward yes. Okay. And so, Lou, why don't you run us through, some of your conclusions based on what we looked at?
Sure. This urban area is one of the fastest growing counties in the United States. There is an opportunity for the medical center to grow enrollment, attract more enrollees, as well as unique patients and users by bringing specialty care closer to where these veterans live. The medical center can increase overall complexity of services it provides to veterans in its catchment area. And increase reliance on VA services as well as FAC work and get more resources from VERA. The urban area has a large enough enrollment, 47,000, to support a full-fledged healthcare center or multi-specialty clinic. The submarket area actually has 35% of the enrollment of the medical center's whole market area. The enrollment rate for this urban area submarket is higher than for the medical center's market area, 68% versus 59%. It's also expected to grow by over 12% over the coming decade. Primary care and all other ambulatory specialties are projected to grow significantly. A multi-specialty healthcare center could make sense to capture this growth and remove pressure at the medical center. Capacity and wait time data indicate there is little room to absorb increases in demand within existing resources. And it would make sense to add capacity in the urban areas submarket. So the overall conclusion would be is it would make sense to pursue the notion of having an expanded multi-specialty clinic or a full-blown healthcare center that can do ambulatory procedures at this location. I want to caution that this is kind of a very high-level review at this point, and before making a final decision, we would probably want to drill all this down further because it is a major commitment.
Absolutely, yes. It was obviously for illustrative purposes, and in a 1 hour webinar we couldn't go too far, but I think it does illustrate that looking across those data sets, that certainly there's a lot of evidence that there's an opportunity here for expansion. And in a real world scenario, yeah, you've got to go a little further with this, but those are the data sets that you'd be looking at, and so it is realistic in that regard, and this could be the beginning of a significant decision that would have long-term benefits for the facility. So
I just want to say two seconds just on, I did mention colonoscopies, and I focused that on one of the slides. And you remember earlier we said that there actually was excess capacity in GI up at the medical center.
Mm-hmm. Yep.
But people don't really want to travel 100 miles to get a colonoscopy. And so it might be a good idea to see if they could move some of that capacity, so to speak, by shifting it down to this submarket where they could delight patients in terms of making this care very accessible, and if there's a cost advantage, producing it in-house versus buying it in the community. So even when there is capacity in the system, it may be in the wrong place.
That's a great point, Lou. And certainly those types of considerations, the veteran experience have to be factored into this. Even as the data tells one story, you also certainly have to look at the qualitative side and see how those things come into play. And hopefully you're finding opportunities that sort of check all boxes. But we also know that's not always going to be the case. So, and Lou, I want to make sure we finish these. So we've got about 15 minutes left, and we do have 2 more examples. They're not quite as long as the first example, so I think we'll be able to make it through. But in example 2, we're talking about potential challenges related to primary care. So can you set this one up for us?
Sure. Very quickly, we have this, as is true in most of the country. The demand for primary care is growing rapidly. Many facilities have problems with waiting times for routine primary care. There may be opportunities to realign how that care is delivered using technologies that are appointment saving or appointment averting, so to speak. and there's a need to consider innovative approaches to providing timely care to patients at the right time using the most convenient venue, and also to consider, can chronic care management be accomplished with less appointments using some of the available technologies out there. So the decision is, what should the primary care delivery strategy be going forward?
Okay, very good. And so in order to do that, we've got here a snapshot of some of the data we'd like to look at. And so we have some of this in a part of our example: projection, capacity, some benchmarking, and some other estimates that, Lou, I think you're going to share some nice some methods that you've developed that'll help take a look at this. So why don't we jump right into it, and why don't we take a peek starting with the primary care demand projection?
All right. So at this particular facility, you can see right off the bat there's going to be rapid growth in primary care demand over the next decade. So let's go to the next slide.
Very significant growth in this particular market. Okay.
What about capacity? All right, and this comes from the PACT panel report, which you can access on VSSC. And although there are some CBOCs, we have the medical center here, and then you have all these different CBOCs, and there are a few CBOCs where there is some additional capacity. But overall, when you lump it all together for this facility, they're actually maxed out. They're actually exceeding the modeled capacity. So there isn't that much slack. In fact, there's probably no slack to absorb increased future workload.
All right, so very important consideration to be made here. And obviously in this example, you don't know the geographic distribution of the medical center and the CBOCs, but bottom line is, as a system, these guys are pretty busy and pretty full. So Lou, so this is a really interesting look here, and this is a methodology that you've helped to develop. Walk us through this and help us understand what we're seeing here.
Okay, so what we've done here, this is for ambulatory medical specialties, and we've taken modeled RVU output for 2017, potential RVU capacity, that came from the capacity report, so potential additional capacity in order to get total capacity. So this is the total capacity. Then we have model 2022 demand and model 2027 demand for all these different specialties. But I'm going to focus on internal medicine primary care. Some of you who really know a lot about these data know that we don't really have, at this point in time, I think it's still the case, productivity data on primary care per se. So what I did is I took primary care demand in terms of RVUs, and I lumped it together with internal medicine. And in order to just get a ballpark on what the gaps are in terms of providers, just assume that productivity standards for internal medicine and primary care were about the same. I know that that's not absolutely accurate, but it just gives you a ballpark of the magnitude of additional providers that might be required in order to meet the gaps. So this is, what they're producing, the additional capacity, the total capacity, demand in 2022, demand for 2027, all this in terms of RVUs. This is the productivity standard. This is a 1A facility, so these are the productivity standards for 1A facility. I'm going to skip these columns right here because they really are something else that I was produced this table for, and I'm going to jump to the last columns. And the last columns, you can see I've got the RVU gap for 2022, which is total capacity modeled minus total capacity. So that's the RVU gap that exists if we don't hire any additional capacity. And the same gap for 2027. And then I have the MD gap. The MD gap, or provider gap, is simply the RVU gap for each year divided by the productivity standard. So if we're talking about internal medicine primary care, we take the gap for 2022, which is 606,227, and this is how much every provider should be producing according to that productivity standard divide that, and we see that we would need 123 additional providers between now and, let's say, 2022, and 139, almost 140 providers in 2027. It'll take 140 providers to meet primary care demand over the next decade if you stick with traditional care delivery modalities, and this is probably not sustainable. To hire all these providers, particularly since most of them are going to need it within 5 years, it's probably going to be very, very difficult to try and achieve that, because it's not just hiring, which is difficult enough, but where are you going to get all the infrastructure to house them?
Absolutely, yeah. So this is a huge, potential gap here, and it raises a lot of questions. Like you said, traditional approach to handling this just may not be a realistic or feasible option. So, so thank you for walking us through that. I think it really truly paints a picture of some need here. And so we wanted to again ask the audience for some input as we analyze this scenario. And this poll here again is another one where we probably queued you up and steered you toward a particular answer, but the question does come down to, does it make sense, or what if you're in the seat, you're the director of the facility and you're trying to figure out this problem, what does it look like to maybe expand some of the other options, like Lou said, some non-traditional approaches that might help dampen some of the demand for primary care. And so votes are coming in. I'll leave it open here for just another second or two. I think we're trending toward a unanimous response that yes, absolutely, something has to happen here. And so for the folks who are still voting, we're getting a lot of yeses here. And let me go ahead and close this one out so that we can move forward. But bottom line is we have consensus. This is something that we don't see too often in this day and age, but we've got consensus that yes, something needs to be done here, and it can't all just be the traditional approach. So just a quick summary for us here, Lou. What's one option here that this particular sample medical center might consider in order to meet this demand?
Well, they need to expand traditional telehealth formats. Most of that now is done inside of CBOX. We really need to move more, MBA needs to move more into home telehealth. Kaiser Permanente has estimated that they reduce overall visits by 0.33 visits per telehealth visit. So that's an overall reduction in visits. Digital health patient contact, and these are real time, not just secure messaging, but real-time interactions using a tablet or a computer or your smartphone can reduce demand for physical visits. Every 3 digital health interactions obviates the need for approximately 1 physical visit. Digitizing wellness and chronic disease management. We bring a lot of patients in order to check on them with regard to their chronic disease management. Some come in twice a year, some come in 4 times a year specifically for those purposes. We need to find other ways to monitor them, make sure that they're adhering to their treatment protocols and they're not running into problems where they do need to come in, but do it in a way that they don't have to keep coming back every few months. And adopting some combination of those modalities that can reduce the need for additional providers by more than half. I will mention, I didn't put that here as a possibility, that there are some medical centers that are considering, actually are experimenting with contracts with chains of urgent care centers to also reduce the demand for coming in for a primary care visit because you have an eye infection or some kind of a skin rash or something along those lines where, gee, either digital health, or if you don't have digital health platform yet, you can run to an urgent care center and get them taken care of. And based upon whatever rules VA adopts, VA would pay for it. And I think you're probably going to see a move toward that as part of the Mission Act as well. This will help dampen some of that demand.
All right, very good, Lou. Thank you. This is a realistic scenario, one that I think we're going to see unfolding in multiple markets. And in many ways, I think VA already is at the leading edge of many of these ideas, but there's going to be real choices to be made, and in order to meet all this demand. So let's look at one last scenario. We'll have to go through this one pretty quick so that we can honor our commitment to end on time. Lou, this one is taking a look at costs. You've got a situation here where you've got this medical center that's got a couple challenges. Can you give us the real quick overview, and then we'll take a look at the data?
So they've got low occupancy. They're worried about whether their costs, that's what's really driving them to, of this inpatient care is driving them to exceeding their VERA allocation, needing to get bailed out, perhaps by the VISN. Excess capacity may be driving admissions. When you've got the beds available, you may tend to admit more than you should. Also let patients stay in longer. And there may be admissions that could have been avoided through better management of patient care in the ambulatory settings, and unit costs may also be high because of the low volumes. So the decision is, first of all, answering the question, are acute inpatient costs too high, and what needs to change?
All right. So a couple different data sources here, which we'll look at, and as we get into the actual data points here. So let's take a quick peek here at this comparative analysis on acute care cost and utilization.
Right, and you could drive this down to the different bed sections or treating specialties. So this is at a very high level. And you can see going through time, let's focus on 2017 data. You can see that for medicine and psychiatry, lengths of stay are high relative to their benchmark facilities. So I should mention, we did put a group of facilities together for this VFC to serve as a benchmark. So they averaged at 4.9 versus 5.9 for this particular facility. For psychiatry, it was 12 versus 9.6. Just for fun, we put the Medicare average lengths of stay here. And then we have average, and these, by the way, are adjusted when we do the comparisons. They're adjusted for case mix. Average total cost per discharge also adjusted for case mix, and we can see that they're considerably higher for medicine, psychiatry versus surgery. So surgery is the only case where they don't have a problem, and you might note that for surgery they were at over 70% occupancy. For psychiatry and for medicine, costs are considerably higher, and notice that psychiatry costs are higher, but their occupancy rate is actually at 95%. So there are other things driving that, probably the excessive length of stay.
Okay, very interesting. And then, so, there's clearly some things that stand out there. And then when we take a peek at the UM data, there's another set of conclusions we can draw here.
Right. Here we look at percent of admissions, reviews meeting criteria, and they're not performing as well as their benchmark facilities. Continued stay reviews, they're doing considerably worse and trending in the wrong direction with regard to the continued stay, so that contributes to length of stay issues. Their 30-day all-cause readmission rate, they're doing fairly well on that. They weren't doing so well back in 2014 when we did this particular facility. When we worked with them, we really didn't have, this is old data, 17 and 18 data, but just trying to give you an overview here. And their ACAC range, ambulatory care sensitive conditions, we see that they're actually performing better. So the issues here are patients being admitted who don't necessarily need to be admitted, but also a big problem in terms of length of stay.
All right. Well, Lou, we were going to do a poll, but in the interest of time, why don't we just go straight to our conclusions, which, from a just quick glance at a couple data points, it becomes clear that these guys do have some challenges with their cost, and that there's some obvious contributing factors to that. Certainly, like you said, the unit costs, the excess length of stay and admissions, I mean, those are issues that are absolutely going to affect the cost, challenges that this particular facility is facing.
Yeah, I just want to mention one thing before we sign off, and that is even if you fix all these things, even if you do a better job in terms of your admissions, discharging patients, and so on. You may not actually drive down costs unless you are able to bring this down to a level low enough so that you could perhaps close a unit. As long as you have all of these units open, you have to staff them. And so what would be really important here is, yeah, you want to do all these things, but the aim should be to get capacity and utilization to match so that you could operate efficiently.
Absolutely. Well, thank you, Lou, for running us through that. I think we just wanted to let folks know that if they didn't already know that if you're inside the VA system, many of these different data sources that we've discussed can be linked from the VSSC website. That's just a screen grab. So if folks are looking for that, that's a great place to get started, and that there's an ability to drill down. So something we just wanted to share, even though most folks probably may be aware of that, just in case you weren't. This is something, and you know, for folks that have attended and you want your perhaps colleagues, or you have some up and coming staff members that might be working on this type of analysis, you know, certainly please share this with them. We are going to email out a copy of, well, what we're going to email out is a copy of the recording of the webinar. So for anybody who registered, we'll send that out, and folks are welcome to share that within the system with colleagues. And, you know, our contact information is here. Please do follow up if you guys do have any questions. Certainly Dr. De Nino, myself, we'd be happy to, you know, support anybody in any way we can. You know, having worked with many medical centers, and again, currently working with 20 sites of all different shapes and sizes and different parts of the country, you know, this and what we do with business planning, we're certainly happy to be of assistance in any way we can in that regard. So thank you all for being on here with us today. Appreciate it. Hope you found it to be valuable, and we will look forward to seeing you next time. And Lou, thank you so much for taking time to be with us and walk us through this.
You're welcome. And thanks to all of you today for joining us.
Okay, everybody, look forward to next time, and we'll certainly look forward to staying in touch. Thank you all.